Sir is a gold medalist in MD anesthesiology and holds prestigious qualifications including FMB in critical care medicine and IFCCM. With over 25 years of extensive experience in critical care, he has been at the forefront of managing complex and high acuity cases, particularly in neurocritical care. Thank you, sir.
About ventilator settings. Now in proper, I assume that you know physiology, you know the concepts of ventilation, and so my job and my colleague's job is easy to win, and quickly we are going to take you through the practical scenario. So in sepsis, sepsis is very common in ICU. You'll get a sepsis patient, and the question arises, why I need ventilation in septic shock. So that was the first question I asked myself. Why the topic is given to me, ventilation in septic shock, why you want? So any answers from your side? Why do you want a septic shock patient to be ventilated? What could be the causes of frequent acute respiratory failure in the patient with septic shock?
Sir, there will be involvement of multiple organs such as if kidney is involved in sepsis, there will be AKI
Yeah.
Fluid overload.
Fluid overload, okay. Now, yeah, that is one. Pneumonia, patient can have directly pneumonia, community acquired pneumonia, he is respiratory failure, he may come. Patient from sepsis for any source, he will, the body will try to regulate, there will be metabolic acidosis. How does the metabolic acidosis patient breathe? So there is the breathing rate is very high. So what we call about the work of breathing. So work of breathing will be high. In sometimes the patient will be obtended with septic encephalopathy, and that patient may require intubation for say airway protection, right? So these are all the causes I could think of, and of course hemodynamic instability. So if the patient is highly hemodynamic instable, we are talking about we are giving the inotropic support more than say noradrenaline, they say more than 5 mic per kg per minute, and the patient is requiring in persistent shock, not going to recover in next 12 hours. So in that patient, using a non-invasive ventilation is contraindication actually. So you should know that there might be acute respiratory failure because of various metabolic causes, as he pointed out, renal failure, infection, septic, and all these reasons you will require a ventilation. That is correct. And the high metabolic demand and the CO2. That's why the patient will require some form of ventilation. May not be ventilation, sometimes oxygenation as well. So this was I wanted to include this was published yesterday. Now they are struggling actually. This study is very good. We are going more towards non-invasive. So doing invasive ventilation, if we can avoid, the first rule is avoid invasive ventilation. That is what we are moving towards. Second rule is, if you are invasive ventilating, use low tidal volume. Madam has already told you. So we are trying to be more of a physiological basis. Now this study they have yesterday released, they have a French study, 42 centers they have taken, and in respiratory failure with PaO2 FiO2 ratio of 200. Mind you, it is 200. What madam told is less than 300 is acute, 200 to 300 is mild ARDS, less than 200 and less than 100 is severe ARDS. So they are talking about PF ratio of 200, where they used high flow oxygen 10 liters per minute with a patient respiratory rate was around 24 to 30, and they used a high flow nasal cannula. The high flow nasal cannula in the morning we have discussed, it reduces the little bit of work of breathing if the patient has generated enough PEEP. So HFNC they tried to compare, and the result was that in HFNC group, you can see on the left side here, there was a pointer there. So there is definitely less incidence of intubation. So they were able to avoid the intubation in patients with high flow nasal cannula. But you have to be very selective in these patients, where you have to be sure that this patient which you have selected is not obtended, or any way you are not delaying the intubation, because you may fall trap of avoiding intubation. Like in COVID we have done, the major problem here is timing of intubation, when to intubate a patient. That is yet not there is no yet evidence, and it is still eminence or experience based. Now in this patient, can I use NIV, high flow nasal cannula, or intubate? You got my question? So septic patient with respiratory rate of 24 to 38 with upcoming evidence, what should I do? I give high oxygen, high flow nasal cannula, I use BiPAP, or I straight away go for invasive ventilation. How many of you want to go for invasive ventilation in septic patient, septic shock patient? We are talking about septic shock. Raise your hands. So I don't want to discourage you, though nobody is raising. You want to use NIV in septic shock? You want to use high flow nasal cannula? But the problem here, again remember, we did this study in 2020, a timing of intubation in COVID patient, because there was resource limited and patients were kept on high flow and NIV, and timing of intubation compared less than 48 hours and more than 48 hours. And we found that those who were intubated more than 48 hours ultimately had a higher mortality. So you have to see how sick is your patient. More sicker the patient, more definitive needs you have to take. So if your patient inotropic requirement very high and his ABG is showing severe acidosis, your trial of all these non-invasive ventilation should restrict to 2 hours. You see the result. If it's not improving, go for invasive ventilation. Don't shy away from invasive ventilation. That is the support that is required, organ support required. So these clinical decisions are you have to take bedside. So that is what is important in ventilating a septic shock patient. Now, persistent hypoxemia, severe respiratory distress, as I told, less than 200, septic NCAF, hemodynamic collapse, and severe metabolic acidosis. These are some of the things which we will aim for intubation. But what happens is, the real ground problem is primary consultant will say do not intubate. Relative will say do not intubate. You as an intensivist has to take a decision. What are my factors and why I need an intubation. Even non-invasive ventilation is not safe. We have seen that it causes the self-inflicted lung injury. So if you have a very high minute ventilation, even on BiPAP, there will be biotrauma, which madam was talking about. So patient will ultimately get intubated, but then delayed. And delayed intubation has high mortality. Now let's give a decision point here. If you have understood the concept, 55-year-old septic shock with developing ARDS, PF ratio is 120. What should I do? You have just learned this. What should be invasive or non-invasive? Invasive, correct? It is less than 200, it's less than almost a severe form of ARDS. And what will be your lung strategy? Lung protective ventilation. So what you heard about the low tidal volume ventilation. So what is lung protective ventilation? You already know. So I don't want to go in detail. Just the target is 6 to 8 ml per kg. Respiratory rate 18 to 24. Though 35 is the limit. No ARDS patient get ventilated on 35. So it is 18 to 24. PEEP of 5 to 10. FiO2 100. Inspiratory expiratory ratio and driving pressures less than 50. So driving pressure is easy to monitor. And peak and plateau will learn in the troubleshooting and ventilator graphics. Will know how important to realize and utilize this. Now, septic patient with volume control mode, 500 tidal volume, FiO2 is 100%, plateau pressure is 32. What should I do first here? So first thing you will do here is reduction of tidal volume. So it's 500 ml. So you can still come down. So that is what how you should individualize each patient. So already tidal volume is low. Then you should think of strategy how to reduce the plateau pressure. What should be my other aim? What should be my accepted CO2? So that you have already learned. So this is same applies for the sepsis-induced respiratory failure. High PEEP, we already know the heart-lung interaction, and because of high PEEP, there is a more positive pressure, less venous return, and more chances of hypotension in this patient. But in ARDS, is it true? It's not true. Why we are going high PEEP? Because lung compliance is poor. The pressures are not transmitted only. So high compliance, because of poor compliance, there is no rapid transpulmonary pressure is not that much. At the same time, respiratory rate, if a high is there, still the air trapping will not be there in ARDS. Why? Because the compliance is so low, the expiration occurs so fast, so deflation occurs so fast. So it is difficult to inflate. The balloon is difficult to inflate. It deflates also fast. So you don't require a long expiratory time. So that's why you can go to high respiratory rate, because there is no risk of air trapping. On the contrary, like COPD we have discussed. What about sedation? We have a very excellent lecture on sedation and neuromuscular blocking agent. In our unit, we have made a policy of using Dexmed. It's so wonderful drug, less delirium, and patient is consciously sedated, and no police will come to tie your hand here. So that was an excellent video actually. So you have to balance here. Now, if I need a ventilation of a septic shock patient for first 24 hours, I don't want him to trigger and cause more hemodynamic. At that time, I can use a neuromuscular blocking, but restrict it to first 24 hours, because if I use prolong, then I will create problem for Dr. Rishikesh. So weaning the patient off will be problem. So there will be ICU acquired weakness, there will be diaphragmatic dysfunction, diaphragmatic atrophy. All this will lead to. So remember, this is mechanical ventilation is the support you are giving for the temporary time being, and ultimately you have to bring back the patient to normal. So that is the idea. Now, when you are ventilating a septic shock patient, don't forget the other part. Fast hug was reported. I think you should know. Vincent has given this. He's a big man, intensivist, father of intensive care medicine. He has given the feeding, analgesia, sedation, thromboprophylaxis, head-up position, ulcer prophylaxis, glycemic control, spontaneous breathing trial, bowel movement, indwelling catheter, and drug. I think you should go through detail in this. This is the screening of the patient. So we have we have given the sister this chart, and she checks. Feeding is given, not given. Why it is not given? Is it bleeding patient? Is the GI bleed is there? Analgesia is receiving or not receiving? So if you have a checklist, so if you see avian industry, so accident nahi hote wahan par avian industry, because there is a check. There is every step when you go to the airport, there is a check, and that increases the level of perfection. So same thing now, ICUs are being compared with aviation industry, and patient is our EA. We should not crash him. So these are the checklists which might help in that situation. Coming to the second scenario now. This topic again Omkar gave me to talk on GBS. So first I thought, why to talk on what is different in GBS? So I tried to search, and luckily I got my own paper in the search. So we had this editorial. So I thought that's why he has given. So this is a prestigious journal of physicians, which I got invited to write an editorial, because we got a GBS patient in clusters in last year. So we have a GBS epidemic, largest epidemic, and that too in Pune. I don't know what, every epidemic comes to Pune only. And so COVID started from Pune. This GBS started, we were troubled. Why these so many clusters? So our ID physician told that this is a shop where from there they are getting that raw thing and Campylobacter jejuni infection. But after 10 days we getting all type of patient, and we geographically position them. They are from all Sinhgarh Road, which was a rapid urbanization, the new development, new project, but no water. And water was from the tanker to the common PMC something, and that was a mess, and that was the source of getting the GBS. And that's why we got so many patients. So this disease outbreak led us to cater most of the GBS patients. So what is different? You already know what is GBS. So I need not say that. And major concern as an ICU person, in the medicine person, ICU person, the ICU person will think why the patient require the ICU admission. So what are the two indications for GBS taking in ICU? One is a respiratory failure, or atypical bulbar weakness, dysfunction, respiratory type 2 respiratory failure. So we talked about since morning type 1. This is type 2 respiratory failure, where the lung parenchyma is absolutely normal. So lung parenchyma is normal, so I need not worry much like ARDS here, right? And 30% of patients this require mechanical ventilation. What are the causes of respiratory failure here? Ascending paralysis, muscle weakness, ineffective cough and secretion. So this is a major issue in these patients. They have very poor cough reflex and autonomic instability. Arrhythmias you see sometimes. And this all leads to hypoventilation, hypercapnia, atelectasis and pneumonia. Sometimes they come with aspiration pneumonia. Unfortunately, very young patients were also in that period we catered, and they were working hands, and even old, young, all type of patient. So decision point, when to intubate. Again, the question is, when to intubate this patient. So if the patient comes with this, you must be calculating this course. Any answer to this? Bilateral facial weakness, difficulty swallowing, MRC score 40/60, which is the best predictor of early respiratory failure. A, B, C, D. C. So Erasmus GBS insufficiency airway scale. Though it looks lucrative, but what at the bedside? I always prefer what I should look at the bedside to intubate the patient. So bedside, you just go to the patient, ask him to do the single breath count. Take a deep breath, demonstrate him. In single breath, 1, 2, 3, 4, my trend is 30. And before the next duty, it becomes 20. Don't give in the night over that it is 30 to 20, now you see. No. This is the patient require elective ventilation. It is don't do crash intubation in the night. The trends are decreasing means that handover period is the time for decision. Then time, if the patient has bulbar weakness, cuff gag poor, this is the time. You ask him to neck lift. If he is unable to neck lift, he is unable to limbs are poor, he is unable to cough out, this is the time to intubate. So any role of NIV? So we talked about so much fancy. There is no role of NIV in GBS. Please don't use NIV. He is a poor cuff gag. He will increase the trouble. No role of high flow nasal cannula. No role of absolutely non-invasive ventilation in GBS with respiratory failure. Please don't try it. So you will increase the problem with secretion, aspiration pneumonia, and the disease is progressive. Now in GBS, when I intubate, I call the relative inside. This is practical. You have to counsel him. Your GBS patient is requiring intubation. You have to counsel the relative that his stay is going to be 3-4 weeks in the ICU. He may require a long-term ventilation. We are giving support. His lungs is normal. He will come out very nicely because mortality is very less if you give cater him properly. And you have to tell him that he may require tracheostomy after 1 week if you are unable to wean. So all this idea you have to take a relative along with you in the journey because they will see that patient is being ventilated daily and nothing is happening. Here we had a young patient himself. You have to communicate with the patient. After 3 days of good ventilation, he got depressed. He stopped when he was unable to move. So there are a lot of depression, psychological element. If the patient is not supporting him, he will not come out. So you have to counsel him also. And we started antidepressant in him. And he started then following and mobilization. So this is invasive ventilation is recommended. These are the clinical predictors I talked about. You can do objective criteria if you have a vital capacity less than 20 mean inspiratory. We used to keep this PEFR in our ICU earlier. So if it is less than 30, expiratory force 20, 30, 40 rule is there. You can take that objective criteria also for intubation, but mostly it is clinical. Now this patient, she has abnormal chest X-ray. What is the most appropriate tidal volume? What is the tidal volume here you keep? So again, see, even if it is normal lung, does not mean that Dr. Sushma has told ki it is abnormal, give low tidal volume. Normal hai to I can give more. So again, you have to prevent the trauma. So 6 to 8 ml, plateau pressure same you have to keep. You will get easily the amount of volume and no need for high PEEP here. So no need for, you have to just maintain the normal capnia, normal ventilation. So maintain the ventilation. What care you have to take is secretions. You have to avoid secondary infection. The GBS patient will die because of pneumonia, ventilator associated pneumonia, if at all it happens in the ICU. So you have to have a good ventilatory care bundle. You have to teach your sister to take adequate position change of the patient. You have to mobilize. We mobilize the patient of GBS on bed, out of bed, on pressure support. You can make him sit in the chair. It's just a support he's requiring. You have to mobilize him. You have to make him feel normal. Even with ventilator, people with portable, you can move the patient. So make him feel normal. It is temporary thing. And secretions you have to take care. So early mobilization and also early tracheostomy if you are thinking that ventilation is going to be prolonged. So these are the timely decisions which you have to do in the GBS in ventilating GBS patient. Sedation strategy, you absolutely understood. Here you have to be very strict about sedation strategy. You don't have to heavily sedate this patient like in ARDS and other things where you require synchrony. Here you have to give minimally conscious sedation fentanyl or your dexmedetomidine will do wonder here. Avoid deep sedation and cuff assist and all be part of care of the patient. Autonomic dysfunction, be ready to monitor these arrhythmias. This may trouble sometimes, bradycardia, hypertension and ICU related complications. So fast hug, I told this patient requires real fast hug. So avoid your pneumonias, DVT, ICU. Don't forget the other part. So we are concentrating on lung, but you have to concentrate on to prevent the DVT in this patient, to prevent the sugar surges, to prevent the infection. All this will lead to ICU acquired complications. So you have to see patient as a whole here. So consider tracheostomy, explain the relative, it will be comforting, easier secretion clearance and facilitate the weaning. So this patient become wonderful. We had a young boy who came out after 3 months and now he is going to the school, he's come back, he's started moving his limbs, everything, tracheostomy scar is gone. So it's so wonderful to see coming out of this, and they are so they remember what doctor told. Now that patient particularly put a rakhi to all our sisters, so he was so I like to share that story very much. So GBS patient, you can prevent mortality 100%, you can prevent the mortality, but timely decision of intubation, ventilation as a whole, avoid ICU complication, and that is the winning challenge is there. So you have to accept that challenge, and you have to give good nutrition is also important in these patients to make them cough and prevent the further complications. So that is how we go for so take home message in GBS is 30% require early recognition. Invasive ventilation is preferred. Don't try NIV. Early tracheostomy often beneficial, and weaning depends upon the respiratory muscle recovery. Prevent ICU complications aggressively. This is actually I have to reach out people. I have started my channel also, so where I give the critical care training session free of cost. I do that. So that is free. You can download if you have so many mechanical ventilation thing also there. Thank you very much.
Do you have any